From clinic halls to late night rounds, questions in your mind, cases, clues, and patient care, all in one straight line. This is the Clinical Medicine Podcast, where practice and the evidence meet. From bedside chat to breakthrough data, clear, concise, and right at your seat. The Clinical Medicine Podcast, making complex things feel clear. Tune in, learn on, stay curious. We're glad you're here. Oh yeah.
Hey everyone, welcome back to the podcast. So why is assessing kidney function such a big deal anyway?
It's super critical because your kidneys are like your body's personal filtering system. They remove toxins and balance fluids.
Right, so if they're not working, everything else just goes haywire.
Exactly. But here's the tricky part. You can't just look at them and know if they're filtering efficiently.
You can't just take a peek and say, oh, yep, looks good.
No, we can't directly measure their function in real time like watching a filter fill up.
Wait, really? So how do doctors figure it out then?
That's where surrogate markers come in. Think of them as clues.
Clues? Like a detective story?
Pretty much. We measure other things in your blood or urine that give us hints about how well the kidneys are doing their job.
Oh, so it's not a direct measurement, but an educated guess based on these clues.
Precisely. And the big kahuna of these clues, the most important one, is the Glomerular Filtration Rate. We call it GFR.
GFR. Okay, so that's like the ultimate clue then.
It's the primary indicator. It tells us how much blood your kidneys are cleaning per minute.
Wow. But if we can't measure it directly, how do we even get to that GFR number?
That's the challenge. We rely on all sorts of indirect methods to estimate it. It's not a straightforward process.
So if we can't directly see the kidneys working, what's the big deal then with GFR, the glomerular filtration rate?
GFR is like the ultimate speedometer for your kidneys.
The speedometer?
Yeah, it tells us how efficiently they're filtering waste from your blood. It's the best single indicator of overall kidney function.
So it's super important to know this number.
Crucial. It helps diagnose kidney disease and track its progression.
Okay, but you just said we can't measure it directly.
Exactly. That's the real challenge.
Wait, so we know it's the best measure, but we can't actually measure it directly?
In routine practice, no. It's too complex and invasive for everyday use.
That's a bummer.
I know, right? So we have to rely on indirect methods.
Like guessing?
Not guessing, more like really smart detective work. We use other markers to estimate it.
So we're looking for clues, basically.
Precisely. Clues that give us a good approximation of that GFR number.
Fascinating. So what kind of clues are we talking about here?
Well, we use things like clearance concepts and creatinine levels. They're our main tools.
Creatinine, I've heard of that.
It's a big one. And then we've got these cool estimation formulas and newer biomarkers, too.
So if GFR is king, but we can't directly measure it, how do we actually get to these numbers in the real world?
Well, that's where our indirect methods come in. We've got a few tricks up our sleeves, starting with clearance concepts.
Clearance concepts? What exactly does that mean?
Think of it as how quickly a substance is cleared from your blood by the kidneys. It's a way to infer how well the filter is working.
So, like, how fast it leaves your system?
Precisely. And the substance we often look at first for this is creatinine.
Creatinine. I've heard that term. Isn't that just a waste product?
It is, but it's super useful because it's produced at a fairly constant rate from muscle metabolism and is primarily filtered by the kidneys.
So higher creatinine means kidneys aren't filtering well.
Generally, yes. It's a key indicator, but it's not perfect on its own.
Yeah, there's always a but, right?
Always. That's why we combine creatinine with estimation formulas, things like Cockcroft Gault or MDRD.
Those sound super scientific.
They are. They take creatinine levels plus age, sex, and sometimes race to give us a more accurate estimated GFR.
So they help refine that creatinine number.
Exactly. They give us a much better picture than creatinine alone ever could. It's all about getting closer to that true GFR.
So we've talked a lot about creatinine, but are there newer ways to assess kidney function that are even more precise?
Absolutely. There's Cystatin C.
Cystatin C? What's that?
It's another protein similar to creatinine, but it's produced by all nucleated cells.
Okay, so it's more stable.
Exactly. It's less affected by muscle mass, diet, or inflammation than creatinine is.
Wow, so that sounds like a big step up.
It can be, especially in populations where creatinine might be unreliable.
Like in kids or the elderly?
You got it. And then there's microalbuminuria.
Micro what now?
Microalbuminuria. It's about detecting tiny amounts of albumin, a protein, in the urine.
Why would that matter?
Because healthy kidneys shouldn't let albumin escape into the urine in any significant amount.
So if it's there, it's an early warning sign.
Precisely. It can indicate very early kidney damage even before GFR declines.
That's super important for catching problems early.
It really is. It helps refine our picture of renal health beyond just how much is being filtered.
So these are like next level markers for kidney health.
Exactly. They give us a more complete and nuanced view.
So after all this, the clearance, the creatinine, the formulas, what are the big limitations we need to keep in mind?
That's the crucial part. Each method, even the best ones, has its blind spots, right?
Blind spots? Like what kind of blind spots?
Well, for creatinine, muscle mass is a huge factor. If you're really muscular, your creatinine might be higher, even if your kidneys are fine.
So a bodybuilder might look like they have kidney issues, even if they don't.
Exactly. Or someone frail with low muscle mass might have a deceptively normal creatinine, even with struggling kidneys.
Whoa, that's a big deal. What about the GFR estimation formulas like MDRD or CKD-EPI?
They're better, but still rely on creatinine. And they often get less accurate at the extremes of GFR, like very high or very low.
So they're not perfect in all situations.
No, not always. And factors like diet, certain medications, or acute kidney injury can temporarily throw off these numbers.
So even with all these tools, we still have to think beyond just the number on the page?
Absolutely. It's about combining the physiological understanding of each test with the patient's whole clinical picture.
It's like a puzzle. You need all the pieces and know how each piece can be a bit tricky.
Precisely. The Cystatin C and microalbuminuria, while newer, also have their own nuances.
Okay, so it's not just about getting a result, but understanding what that result actually means in context.
Yes, there are physiological bases and their practical limitations in the real world.
That's a much deeper way to look at it.
Well, that's a lot to think about.
Yeah, for sure.
Thanks, Rachel.
Thanks for having me.
Back to the podcast. Rachel, how are you doing today?
I'm doing fantastic. Thanks for having me, Cam.
So let's kick things off with the basics. What exactly are we talking about when we say renal function assessment?
Great question. We're essentially trying to figure out how well your kidneys are working, their overall activity.
And how do we do that?
The main way is by looking at something called the Glomerular Filtration Rate, or GFR. It's our key surrogate marker.
A surrogate marker.
Right. We can't directly measure every single thing the kidney does, so GFR gives us one number that's a really good stand-in.
Like a performance score for your kidneys?
Exactly. It tells us the volume of fluid filtered by the glomeruli in your kidneys per minute. It's a snapshot of their filtering power.
So the higher the GFR, the better your kidneys are filtering.
Generally, yes. A healthy GFR means your kidneys are efficiently removing waste from your blood.
And why is it so important to know this GFR number?
Because kidney function impacts everything, from how you process medications to your overall health.
So it's not just about the kidneys themselves, but what they affect throughout the body.
Precisely. It's a critical indicator for your health.
So we've talked about GFR as this big umbrella for kidney function, but what's this clearance concept?
Clearance is actually a super elegant idea. It's essentially the volume of plasma that gets completely cleared of a specific substance every minute.
Cleared of a substance?
Yes, think of it like this. If you have a substance in your blood, say X, clearance tells you how much blood volume the body processes to totally remove X from it in a given time.
So it's not just about the kidneys then?
Exactly. That's the cool part. While we often think of it with kidneys, the principle applies to other organs too.
Oh, like what?
Well, your liver clears drugs from your system, right? That's hepatic clearance. And your thyroid clears iodine for hormone production.
Wow. So it's a fundamental biological process.
Absolutely. It's just a way to measure how efficiently an organ or the body can remove something.
And for kidneys, it's about filtering the blood.
Precisely. The higher the clearance, the more efficiently your kidneys are filtering that specific substance out of your plasma per minute.
So it's a rate.
A volume per unit time, yes, usually milliliters per minute.
Makes sense. And this helps us understand overall kidney activity?
It gives us a really solid, quantifiable estimate of that activity.
So that clearance concept is not just for kidneys, right? You mentioned liver and thyroid, too.
Exactly. But for kidneys, we need to pick the right substance to measure that clearance.
What kind of substances are we talking about?
There are endogenous ones like creatinine and urea, which our bodies produce.
Endogenous, so they're naturally in us.
Yes. And then exogenous ones, which we introduce like inulin or even some radioactive compounds.
Radioactive? That sounds intense.
It can be, but the idea is the same. They're filtered by the kidney, and we measure how much plasma is cleared.
So what's the go-to then? Which one do doctors usually use?
Creatinine. It's the preferred choice despite some limitations.
Why creatinine? Is it just easier?
Precisely. It's naturally occurring, so no injections needed, and labs measure it routinely. It's cost-effective.
Ah, practical advantages. So it's not perfectly accurate, but it's convenient.
You hit the nail on the head. Inulin, for example, is considered the gold standard because it's only filtered and not reabsorbed or secreted by the tubules.
But it's not used as much because...
It requires an injection and isn't as widely available. Creatinine is a great compromise between accuracy and practicality for routine assessment.
So, after we've picked our substance, how do we actually calculate GFR in practice?
Right. The gold standard involves a 24-hour urine collection.
24 hours? Like every single drop?
Precisely. The patient empties their bladder first thing in the morning, say at 7 a.m., and discards that urine.
Okay, so that's the starting point.
Yep. Then every single urination for the next 24 hours goes into a special container.
Even the next morning 7 a.m. one?
Exactly. All of it. From that, we get the total urine volume in milliliters.
And then what happens?
We measure the concentration of our chosen substance, like creatinine, in both the collected urine and a blood sample.
So you need urine concentration and plasma concentration.
That's it. And to get the urine volume per minute, we divide the total 24-hour volume by 1,440.
1,440 minutes in a day. Got it.
Then we plug those numbers into the clearance formula. Urinary concentration times urine volume per minute divided by plasma concentration.
And that gives us the GFR.
That's your GFR in milliliters per minute.
What's the normal range for that?
For adult men, typically 90 to 120 milliliters per minute. For women, it's a bit lower, 80 to 110.
So if someone has a GFR of 70, that's already a concern.
Potentially, yes. It indicates reduced renal function.
So after all this collection and calculation, why is GFR so critically important in a clinical setting?
Well, it's absolutely vital for two main reasons, especially around drug dosing.
Drug dosing, really?
Yeah, many medications are eliminated by the kidneys. If a patient has reduced GFR, their body can't clear drugs effectively.
So you'd have to adjust the dose, right?
Precisely. Without GFR, you risk overdosing, which can be really dangerous, or underdosing, making the medication ineffective.
Okay, that makes a lot of sense.
The second big area is radiology, especially with contrast agents.
Like for MRI or CT scans.
Exactly. Iodinated contrast is toxic if the kidneys can't remove it properly. A low GFR means we might need to modify the procedure or even avoid the contrast altogether.
So it prevents kidney damage from the contrast.
That's it. It guides decisions to protect kidney health.
Wow. So GFR really influences a lot of critical medical decisions.
It's fundamental. Understanding a patient's renal function through their GFR is non-negotiable for safe and effective care.
It sounds like a central piece of the puzzle.
So after all that, we're back to creatinine. What are its big pros and cons?
Well, the advantages are huge. It's cheap, it's naturally produced, and laboratories measure it routinely.
So it's accessible.
Exactly. And theoretically, it's 100% filtered by the kidneys.
Theoretically?
There's the rub. The disadvantages start with tubular secretion. About 10% of the creatinine in urine actually comes from the renal tubules, not just filtration.
So it's not a perfect marker.
Far from it. And in kidney failure, that tubular secretion can increase by 15 to 20%.
Wow.
It also depends heavily on muscle mass. A very muscular person will have higher creatinine levels than someone less muscular, even with the same GFR.
So it's not a one-size-fits-all reading.
Definitely not. Diet influences it too. Eating a lot of meat can temporarily increase creatinine.
Wait, really?
Yes, and there's also bacterial breakdown in the gut, which means not all creatinine is filtered by the kidneys.
Okay, so many variables.
Plus, other compounds in the blood can interfere with the lab tests, making results inaccurate.
So that 24-hour urine collection sounds super important for GFR, but it also sounds tricky. What are the practical problems?
Oh, it absolutely is, especially with elderly patients.
Why them specifically?
Cognitive issues, memory problems, they might forget to collect or miss some of the urine. It's a full day of collection, remember?
Right, from that first discard in the morning. So if they miss even one void.
It completely messes up the volume calculation, which then throws off the entire GFR result.
Wow, that makes the accuracy really tough.
Exactly. Another issue is urinary retention, where patients can't fully empty their bladder.
So they think they've collected everything, but they haven't.
Precisely. This leads to an underestimation of the total urine volume. Again, skew GFR.
So what did doctors do to try and make this work better?
Written instructions are key, very detailed ones. And for those with cognitive deficits, caregiver support is crucial.
Makes sense. Someone to help them remember.
Yep. And in situations where maximum accuracy is needed, like for transplant patients, they might even use exogenous tracers.
Tracers? What are those?
Special substances given to the patient, then measured in blood. No urine collection needed.
Oh, so like a bypass for the tricky collection.
Exactly. But they're more expensive and not always available. It's a trade-off.
So we've talked a lot about urine collection, but what if you don't want to collect urine for 24 hours? Are there ways to estimate GFR without all that hassle?
Absolutely. There are formulas that use just a blood test for creatinine. Two common ones are Cockcroft, Gault, and MDRD.
Okay, Cockcroft Gault. How does that one work?
It uses age, weight, and plasma creatinine. And for women, you multiply the result by 0.85 because of lower muscle mass.
So it's simpler than the 24-hour collection because it's just blood and a few patient details.
Exactly. But then there's MDRD, which is even more sophisticated.
MDRD. What's different about that?
It doesn't use weight. It factors in creatinine, age, gender, and ethnicity, specifically a correction for African Americans.
Wait, ethnicity. How does that impact the calculation?
It's to account for physiological differences. For example, African Americans tend to have higher muscle mass, which influences creatinine levels.
That's wild. like these formulas are just trying to get a more accurate estimate without the patient having to do all the collection work.
Precisely. They make GFR estimation much more accessible for routine clinical practice.
And they're just using that single creatinine blood test?
Yup, plus those specific patient demographics. It's a balance between convenience and accuracy.
Convenience is a big plus there for sure. So if creatinine has all these limitations, what about other markers? Are there alternatives when creatinine just isn't cutting it for sensitivity?
Absolutely. One of them is beta-2 microglobulin.
Beta-2 microglobulin? That's a mouthful.
It is. Think of it as a tiny protein filtered by the glomerulus.
Okay, so like creatinine, it's filtered.
Yes, but here's the difference. It's almost entirely reabsorbed by the tubules.
Reabsorbed. So it doesn't usually end up in your pee.
Exactly. Normally, it's hardly detectable in urine.
So if it shows up or if levels are high in the blood, that's a red flag.
Precisely. If there's kidney damage, specifically to the tubules, or reduced filtration, it accumulates in the blood.
So it's like an early warning system for a specific kind of kidney damage?
More like an indicator, when creatinine might still look normal, especially if there's tubular dysfunction.
That's super useful for those gray areas we talked about.
It gives us more granular insight,
when creatinine alone isn't telling the whole story.
So it's not just about filtration, but how the tubules are doing too.
Yes, it provides a broader picture.
So we've talked about the limitations of creatinine, right? What about Cystatin C? Is that a better option?
Oh, Cystatin C is fascinating. It's a protease inhibitor from nearly all nucleated cells.
Okay, so not just muscles like creatinine.
Exactly. This means it's independent of age, weight, sex, and muscle mass. Huge advantage.
Wow, so it's consistent across everyone.
Pretty much. It's freely filtered by the glomerulus, but then completely reabsorbed by the proximal tubule.
So it doesn't show up in urine.
Nope, not normally. The cool part is its sensitivity. It detects even small drops in GFR.
Like what kind of drops?
Even when GFR might just be 88 milliliters per minute, creatinine would completely miss that early damage.
That's incredible for early detection.
It really is. The catch, though, is the cost. It's more expensive and not as widely available as creatinine testing.
So it's like a premium option for when you really need precise early readings.
Precisely. Reserved for when early identification of renal damage is absolutely crucial.
So it's better, but not accessible to everyone yet. Got it. So if Cystatin C is this super sensitive early warning system, what about microalbuminuria? Is that another layer of early detection?
Absolutely. Microalbuminuria is exactly that, an early indicator of kidney damage.
Okay, so what exactly is it?
It's the presence of small amounts of albumin in the urine, but only detectable with super sensitive tests.
Small amounts, so regular tests wouldn't even catch it.
Not under 300 milligrams per 24 hours. That's the key difference.
And what's the range for microalbuminuria then?
It's between 30 and 300 milligrams in 24 hours.
And anything above that is just regular albuminuria or proteinuria.
Precisely, over 300 milligrams, and it's considered overt albuminuria, which usually means more advanced kidney damage.
So who should be checked for microalbuminuria?
It's crucial for monitoring patients at risk, especially those with hypertension or early diabetic nephropathy.
So this allows doctors to intervene really early.
Yes, it enables intervention before significant proteinuria even appears. It's a proactive approach.
That makes so much sense. Catching it before it becomes a bigger problem.
So after all this, it sounds like there's no single perfect test, right?
Exactly. It's all about combining everything we've talked about.
The GFR calculation, creatinine clearance.
And those alternative markers like Cystatin C and microalbuminuria.
Each one gives you a different piece of the puzzle.
Yes, because what you choose depends on the patient and the situation.
So for some, creatinine is fine.
When cost is a major factor or if early detection isn't the absolute priority.
But for others, especially those high-risk patients, you need the more sensitive stuff.
Precisely. The Cystatin C, the microalbuminuria.
Even with the higher cost.
It's a balance between cost, how available the test is, and the level of accuracy you need.
So you're saying a comprehensive evaluation means using multiple tools?
Absolutely. It's like building a complete picture of kidney health.
Not just one snapshot, but a whole album.
Precisely. Each method has its strengths and weaknesses.
And we have to use them all intelligently.
To give patients the best care and catch issues early.
So that was a super dense episode, but so much vital information.
Right? We really packed it in there.
We started with GFR physiology, which is like the core of everything.
Absolutely. Understanding how filtration works is key.
And then we moved on to clearance, how the body gets rid of waste.
Which directly relates to GFR. They're intertwined.
Then serum creatinine, that was a big one. Its role and all its limitations.
Oh, definitely. It's not as simple as just one number.
No, it's really not. And that's where the estimation formulas come in.
Like Cockcroft Gault and MDRD, super important for accurate assessment.
So those formulas help us get a better picture when creatinine alone isn't enough.
Exactly. They add crucial context.
And then we talked about the additional tools like Cystatin C.
Yes, that's a real game changer for certain patients.
In microalbuminuria, which is super important for early detection.
For sure, detecting those tiny protein leaks early can make a huge difference.
So we really cover the whole spectrum of kidney function assessment.
From the basic physiology all the way to advanced diagnostics.
It's like a comprehensive guide.
Exactly. Everything you need to know about how kidneys are evaluated.
And I love how we broke it down into understandable chunks.
That's always the goal, to make complex topics accessible.
Because this stuff is vital for clinical practice.
Absolutely essential for patient care.
So to our listeners, if anything from today's episode
felt a bit murky.
Or if you want us to dive deeper into any specific aspect,
Please let us know in the comments. We read every single one and genuinely value your feedback.
seriously, your questions help us make the next episodes even better.
They really do guide our content.
And what about future topics? Any other nephrology subjects you're itching for us to explore?
We're always looking for new ideas to keep things fresh and relevant. We're really excited for what's next.
Thank you so much for tuning in.
It's always a pleasure.
We'll see you in the next episode.
Right here on the Clinical Medicine Podcast.
Bye, everyone.
See you next time. All right, I think that covers it.
Yeah, definitely.